Dear colleagues, good time of the day. I am Jana D.Javakhishvili. Let me open my presentation and I will show you also my institutional belonging. I am Jana D.Javakhishvili, clinical psychologist, professor of psychology at ILia State University, and also I work for the Non-Governmental Federation Global Initiative on Psychiatry, FGIP we call it. I am very happy and honored to have this opportunity today to share experience of mine and my colleagues of building trauma-informed and trauma-focused services in the different countries, but today I will be focused mainly on Georgia. So contents of my presentation, within the context of my favorite Kapczynska's Mona Lisa, is framework for mental health and psychosocial interventions during and aftermath of armed conflicts, levels of interventions, some data available on mental health needs of war-affected populations, and I will speak about what do we mean under trauma-informed approach and services and trauma-focused services, bringing example of the services that me and my colleagues developed in Georgia. So I will start with my favorite framework for the longitudinal phases of disaster by Sundance. Why I appreciate this framework? Because, first of all, it shows that, well, in spite of the fact that event might last for years, like now, tragically, Russian attack on Ukraine, hope it will stop soon with victory of Ukrainian armed forces and Ukrainian people. Whatever length of event we are facing, then we need much longer period for dealing with the consequences of the armed conflict. And usually I say here that the main resource which we need here, that's patience and persistence. Another thing that this framework is showing us, that we should work at different levels actually with different aims to cope with damage, to change functioning of the society and services, to achieve relief, to aim and achieve recovery. And it needs time, but what is the most important thing? We can aim for building better principle. So to use reframing technique, I would like to say that whatever difficulties we as mental health professionals face during and aftermath armed conflicts and wars, actually we need to consider this as a chance to build better mental health system. And your Congress actually is one of the best examples of that. Yeah, you are gathering and trying to reflect how to build community-based services. I will bring another favorite model of mine, which is developed by Vikram Patel and his colleagues back in 2018, showing contemporary approach, comprehensive contemporary staging approach to classification and treatment of mental disorders. Because speaking of building better principle, we need to actually imagine what we are going to build. And Patel and colleagues are proposing to build a staging approach to mental health care and to start there where mental health problems do not exist yet. So that's a mental well-being stage. When people are functional, asymptomatic, but already here, we need to plan preventative interventions like public mental health promotion, illness prevention, etc. The next stage is when, and actually symptoms here are shown like raindrops, colorful raindrops. And raindrops might increase in size together with actually deterioration of condition of mental health. So the next stage, that's non-specific mental distress, that's, let's say, that's stage A, 1A. So here we don't have specific symptoms, but person might worry, person might have insomnia, as many during wartime. Person might have lack of energy, etc., etc. And here we are again proposing preventative informations, self-help promotion, peer support promotion, identification of stressful or complicated and difficult environments and trying to diminish their negative influence, exploring ways of environment modification, though I know what you think, it's very difficult during wartime. If we are not efficient at the first stage and the next stage, which I described, then raindrops might increase in size, and then subsyndromal or subthreshold, as we call symptom profile, might develop. And again, here we have to deliver preventative interventions, or let's say early interventions, or/and, let's say. And here we can think of transdiagnostic approach, and I will speak of transdiagnostic approach later in my presentation. But if we are not efficient to provide mental health promotion, self-help, peer support, and transdiagnostic interventions at earlier stages when the syndrome is not developed yet, then the raindrops are increasing and fully defined syndrome might develop, like anxiety, depression, post-traumatic stress disorders. And here we already need treatment. And of course, it's more costly. And if we are not efficient to provide timely, comprehensive, multidisciplinary services at this stage to provide best possible evidence-based treatment, then it might develop as a recurring condition, persistent condition, and the largest raindrops correspond to treatment-resistant forms. So better to start here and to have all the way along appropriate interventions accessible at community level, then actually intervene when it's already fully developed syndrome or persistent or treatment-resistant condition. So I would like just to land this staging model for mental health care on the pyramid, which somehow at some extent resembles well-known interagency steering committee pyramid, but it's, let's say, kind of variation. So I would like to start with the statement that it is well known from the evidence that in the case of disasters, most affected individuals, families, and communities demonstrate resilience, and resilient response is the most widespread one. And we know that starting from McFarland and Williams studies, but in the last years, George Bonanno just in a very convincing way demonstrated that the most widespread trajectories of mental health responses to the disasters is resilience response. But anyway, if we remember this model, we know that even when mental health well-being is there, we need to promote health. We need to, in case of symptoms, we need to promote self-help and peer support, etc., etc. So we are doing universal preventive interventions here. At next stage, and that's less people who need it, we are working with the risk groups. And these risk groups are actually, in case of armed conflict, displaced people, forced migrants, children and adolescents, elderly people, veterans, ex-combatants, combatants, families who lost their family members. So we need to identify risk groups and take care of preventative interventions with the risk groups or early interventions. But those who are having already developed symptoms, let's say subthreshold conditions, we need to intervene here. But you see, it's again less amount, smaller group of size of population needs it. But here we are delivering targeted prevention, and this might be already trauma-informed service, multidisciplinary one, which I'm going to present at the end of my presentation, the last part of my presentation. And for those who already are revealing mental health symptoms, we need early intervention. And there is a smaller size of population which needs specialized, advanced, trauma-focused interventions. Just to move to my main topic of today's presentation, at all these universal selective prevention, targeted prevention, early intervention levels, we are speaking of trauma-informed mental health care. And here at early intervention level, we are already actually that's a crossroad for trauma-informed and trauma-focused interventions, and on a specialized, advanced care level, that's interventions delivered by highly specialized professionals in trauma-focused interventions. So here we are going up with trauma-informed interventions and ending up with trauma-focused interventions. And what is it about? Let me now speak about what we are speaking about when we use term trauma-informed. So trauma-informed care is a paradigm that recognizes the role of traumatic experiences in many mental and physical health-related conditions. Probably you remember back in 90s, Vincent Felietti's study. He was working in obesity clinic, and he was dealing with the people who had weight-related problems. But all of a sudden, actually by accident, I will not say the whole story, but I'm sure you know, he found out that almost majority of his clients, especially those who dropped out from treatment, had so-called adverse childhood experiences. So trauma, actually traumatic experiences from their childhood. So it's so important to be trauma-informed. So to recognize the role of traumatic experiences in mental health and physical health-related conditions. That's trauma-informed care. Trauma-informed care recommends that specific policy principles should be adopted by health and social care systems, organizations, schools, to increase awareness of trauma, to avoid re-traumatization when we are teaching children or treating children or adults or elderly, to facilitate their recovery. Actually, some authors consider trauma-informed care as useful framework for broader social policies, like economic projects, social projects, advocacy projects, and they are actually distinguishing the following key principles of trauma-informed care: providing safety to the clients, trustworthiness and transparency, collaboration and peer support, empowerment, giving choice to our clients, and intersectionality of identity characteristics. So that's about trauma-informed approach. And trauma-informed services mental health services are sharing all these principles and actually recognize and take care of the role of traumatic experiences in any mental health and physical health related conditions. Let's go further and have a look. And have a look of what we mean under or by trauma-focused services. So that services that provide highly specialized care to individuals suffering from the consequences of traumatic stress. Usually, such services use multidisciplinary case management to satisfy the various needs of clients, because needs are health-related, physical health-related, because if client is tortured or sexually abused, there are physical health needs. Clients have mental health needs. They have even legal needs, social needs. So all these needs need to be targeted. And for treatment of stress-related conditions in trauma-focused services, so-called evidence-based trauma-focused intervention therapies are used, like trauma-focused CBT, EMDR, STAIRS, etc., etc., etc. Now I will just quickly remind you of some evidence about mental health needs of war-affected populations. I will quickly go through some studies which together with my colleagues we implemented in Georgia and then actually in Ukraine, but back in 2016 in Ukraine. So that's Georgian graph, where you see that war-affected population, and it was a study done by Nino Mahashvili and her colleagues back in 2012, and she studied representative sample of the IDP population and population which lives in our gray zone, in the conflict zone. So you will see that PTSD prevalence among this population was more than 20%, while cross-sectional lifetime prevalence of PTSD from 26 countries, it's a study from 26 countries by Cohen and colleagues, is just 3.9. So you can see the difference. So 14% of war-affected populations then suffered of depression, 10% of anxiety, more than 5% with all these three conditions, and at least one disorder, actually among almost 30% of the studied population. It's interesting that those who return to their houses after forced displacement had a bit better mental health condition, returnees, than internally displaced people. So that's also a lesson to learn in when we are thinking of policies. In spite of the fact that people who live in a very risky zone, very difficult situation, their mental health condition was a bit better than of those who were not able to come back to their houses and homes. So another lesson to learn from the study is that most at-risk populations are those who more frequently are exposed to traumatic events, female gender, older age, displacement status, low level of neighborhood support and perceived social support, poor community conditions. That's why economic projects actually play a good role in small business projects, and community mobilization and development activities might play a good role in preventing mental health conditions. And those who had more than one condition, especially three conditions, that was about functional disability, higher levels of functional disability. Actually, only 24.8% of those who revealed mental health problems were receiving health care. And that's a very important thing to remember and keep in mind, because just 1/4 of those who are in need were receiving mental health care then. And another 20% knew that they had mental health problems, were aware of the mental health problems, but did not seek for help for this or that reason. And more than 50% actually even did not realize that they had mental health problems, and they did not were not aware that they need treatment. Actually, the similar epidemiological study we've conducted back in 2016 among Ukrainian internally displaced persons, and I very well realized that today the situation might be absolutely different, deteriorated due to ongoing war conditions, but probably it's interesting to see what was going on already. That was representative sample of IDPs back in 2016. So you see that PTSD level is pretty high, anxiety level as well, and depression level as well. And all these three conditions, 9% of the respondents were suffering from all these three conditions. And the risk factors were pretty same as of Georgian war affected population. So women more vulnerable, elderly more vulnerable, those more vulnerable whose high household income was very bad, and those who actually were lacking community support were more vulnerable. I would like also to show you, I will skip this, to show you the mental health gap, the treatment gap, sorry. So it's also 75%, very similar to Georgian situation. Only 1/4 of those who were in need were receiving mental health care. So how to respond to this situation? And again, I will speak of trauma-focused and trauma-informed services. Actually, together with my colleagues, I am honored to have experience of helping our Ukrainian colleagues to build trauma-focused services back in 2000, in the period of 2014-17. Now, as the war is ongoing, we actually, together with the Federation Global Initiative on Psychiatry and Czech Institute for Public Mental Health, we organized digital mental health services for those who need mental health care during war, because during war it's very different situation, and we need to be creative to make mental health care accessible. Actually, all the Ukraine in the summer bombage service, and if you are interested, you can just see the links from my presentation. We are having Ukrainian team of professionals who are serving people in need due to actually war-related mental health problems. But I'm going to focus on Georgian experience, actually, how we built trauma-informed and trauma-focused services in Georgia. So I would like to say that that's a systemic approach. You need to actually promote stress and trauma-informed policies at policy level. You need to build capacity of the mental health staff, and that could be university education, and we actually established psychotraumatology master program at ILia State University. That's ongoing training, lifelong training in psychotraumatology, basic course, advanced course. That's trauma-specific supervision. It's very specific clinical supervisions that trauma-focused services need. Research, we cannot go further without research. Guidelines, protocols, literature translation. So all this work is going on at meso level, and at micro service level, we are building, actually identifying service gaps and building and piloting, and then measuring effectiveness, and then multiplying innovative, comprehensive, community-based, multidisciplinary services. So I would like to speak briefly about Georgian Center for Rehabilitation of Torture Victims. That's trauma-focused service, which was created back in 2000, and now it's nationwide network of trauma-focused services in the country. Starting from 2013, we actually piloted a trauma-informed family and child care center. That's multidisciplinary trauma-informed service for children and adolescents. And back in 2013, actually, Ministry of Education incorporated this service into its psychosocial service, and now it's nationwide network of trauma-informed services, mental health and psychosocial services for children and adolescents, which are serving public schools and not only. And since 2018, we actually established trauma-informed service for adolescents and youth, so-called Club Synergy. You can actually visit the links. And the same year, we established trauma-informed students counseling center within the university. And that's also probably way to go to increase coverage of the population in need. So, Georgian Center for Rehabilitation of Torture Victims, trauma-focused service, staffed with psychiatrists, psychologists, social workers, physiotherapists, even gynecologists for survivors of sexual violence, art therapists, lawyers. Lawyers are working on cases of human rights violation and filing for the international courts, Strasbourg, etc., etc. And principles of work and modus operandi of the service is community-based, easy to access, free of charge, non-medical setting in ordinary flat without a medical uniform, white, green, or blue uniform, non-governmental, donors funded, because it's about torture victims rehabilitation. And there are torture cases from the side of the state, we know, and not to depend on the state funding. We are donor-driven, multidisciplinarity, client-centered approach, both in-center and outreach activities, for example, at IDP settlements, and trauma-focused evidence-based therapies are delivered within the center, as well as other modules of work. Regular staff care and supervision to avoid professional burnout and secondary traumatization. So now, briefly about mental health service for adolescents and youth, so-called Club Synergy. So that's multidisciplinary psychosocial community-based service for adolescents and youth in the age range between 14 and 25. Now currently functions since 2018 in the two cities of Georgia, Tbilisi and Batumi. It's staffed with psychologists, addictologists, social workers, medical doctors, somatologists, and in case of need for psychiatrists, we are actually having part-time psychiatrists because that is trauma-informed service. Mandate, it serves to youth with emotional and conduct-related problems, among them addiction-related problems. So, methodological background of the service is that that's transdiagnostic approach. Transdiagnostic approach is based on evidence for many different mental disorders. Actually, this evidence states that many different mental health disorders share common vulnerabilities and symptoms like emotional dysregulation, insomnia, anger management problems, etc., etc., communication and interpersonal relationships problems. So transdiagnostic interventions are aimed at reducing and managing these vulnerabilities, not at treatments of disorders, because disorders are not fully developed yet. So transdiagnostic approach addresses subthreshold, subsyndromal conditions. A systematic review proved that transdiagnostic interventions are effective with anxiety, depression, also post-traumatic stress disorder, and also with people with addiction problems. Also, some studies show that transdiagnostic interventions are effective while working with children and adolescents for dealing with mental problems and risk factors. The club synergy actually elaborated and implies now in work with their clientele emotion regulation module, different transdiagnostic modules, for example, anger and conflict management, etc. Effective communication and interpersonal relationship skills module, art therapy module, positive parenting module, brief addiction module based on WHO assist intervention, and also stress management module starting from COVID era. So, in case if we are dealing with the already formed, fully developed syndrome of PTSD, for example, or complex PTSD, then the service still has psychotherapists who provide trauma-focused cognitive behavioral therapy, so-called advanced modules, CBT-based interventions for addictions, for gambling, and EMDR. Algorithm of intervention. First of all, triage, which actually filters those who have, for example, severe mental health disorders or neurodevelopmental disorders. They are not fitting club synergy mandate and are referred to other relevant institutions and services. Initial intake, interview, and routine screening is going on. Then case conceptualization, case planning, and case manager actually oversees the case. Then, based on individual treatment plan, transdiagnostic basic intervention modules like, for example, emotional regulation module, interpersonal skills development module, both individually and it could be delivered with groups, and also positive parenting module for families. Advanced intervention in case if needed after careful assessment, and after intervention is finished, post-assessment is conducted, post-intervention assessment, and in 3 months follow-up assessment is conducted. Just to show you that this kind of approach works, we were conducting studies all these years. Study started in 2019, finished in 2023. So we collected a lot of results on pre, post-test, and follow-up observation. Pre is orange, post is red, and brown is follow-up after 3 months. We were doing study in cooperation with Cardiff University and Ratio International Foundation. And you can see that for general anxiety disorder symptoms, that's pre-intervention, high scores. That's post-intervention, almost half a size of scores. And after 3 months, it's even, it goes on actually. After 3 months post-intervention, the results are improving. The same for screening of depression. That's pre-intervention scores of our clientele. That's post-intervention, almost halved scores of depression, and that's 3 months after intervention was finished. Again, improvement is going on, and that's about life quality improvement. That's mental health life quality screening tool that was lower pre-intervention, higher after intervention, and these results are improving. So that's why I vote for actually pyramid of care to build pyramid of care, starting from universal prevention, but having trauma-informed, preventative, multidisciplinary services as club synergies, and in case of need, we can have very specialized trauma-focused interventions. All of those should be available and easy accessible for our clientele. And then we will be comprehensive and we will implement the staging model, which will definitely be building better principle in place. Thank you very much, and I wish you success, both in terms of your Congress, but also with your future work on building community-based mental health and psychosocial support services. Thank you very much.